So thank you for this nice presentation and case. I'm really surprised that you asked the Dutch surgeon to convince all the American surgeons to operate on an obese patient, but okay, I'll try my best. So I have no disclosures, not relevant for this talk. So the symptomatic umbilical hernia, this lady is really in pain, it's obstructing her mobility, she has to do some rehabilitation after her knee revision surgery. I think there's only two ways to go. It's going to be weight loss or it's going to be surgery. So if you want to wait and modify the risks, weight reduction will really decrease your symptoms. It will decrease your risk of diabetes or having diabetes, and it will decrease your risk of complications. So it's a great option. But there are true risks to waiting. Her symptoms can increase, her hernia defect can get bigger, which will limit your operation options. And if she incarcerates, you have a really problematic case. You'll take an elective case and make it into emergency. Your MIS will probably need to be open, even laparotomy, and a clean case will become a contaminated case, which in her case is something you really don't want. So weight loss, there's two ways to go. You can diet or you can do bariatric surgery. So if you do a diet, and there have been great studies out there. So if you look at the y-axis, it's 4 kilograms of weight loss. It's around 8, 9, maybe 10 pounds. If you really put into it, your patient's really getting into there, it will take a few months and it will have really limited effect. Bariatrics, on the other hand, is going to have great results. So the left side, the axis, is actually percentage of weight loss. So after 9 months, you have a great weight loss. Her symptoms will be decreased. She probably doesn't even need surgery. But getting into bariatric surgery really is a life-altering decision for a patient. You need a really motivated patient that will change their lifestyle. And she's not here for that. She just wants her hernia fixed so that if she's recovering from her knee surgery, she'll have her abdominal wall to help her rehabilitate and lose the weight, probably on her own when she's mobile again. And it's not that uncommon to operate on obese patients in America. So this is a great study out of 2015 looking at ACS-NISQIP database. And if you look at all these ventral hernia repairs, which include incisional hernia repairs, which are truly a different case than an umbilical hernia, you can see that over 60% of the patients operated in America is obese and has a BMI over 30. But looking at their results, it's actually quite good. Like, the amount of wound infection is low, the amount of pneumonias and other problems are low, and if you look at minimal invasive surgery, it's actually quite great. Why would you not operate on them? And we have great ways to do it. You can fix it laparoscopically, put in an IPOL mesh, that will be a nice, easy case, will be a quick case. Or if you have the robot, the ergonomics of the surgeon are also important. You can really do a beautiful repair with an extraperitoneal mesh. You suture the defect, put the mesh in, and close the peritoneum. And looking at the little bit bigger defect, which in her case is not even really necessary, you can do a beautiful different options. For example, TERAPs, where you also suture her diastasis recti. You can put in a big mesh and you suture up the lateral side of the posterior rectus sheath, and it's a great repair. Patient won't have any complications, and she will be really, having a lot of benefit during her knee rehabilitation. So, would you repair this umbilical hernia in this specific patient? Well, her weight loss is really unlikely to happen. You will avoid emergency surgery, and you will really aid her knee surgery rehabilitation. So, yeah, you should, but preferably MIS. Thank you.